Good morning, everyone. I am Anna Tanke and I will be presenting the histopathology report. But before I begin, I would like to thank my advisor, Dr. Andrea Mendoza, for her guidance in this presentation. For a brief review of the histology of normal skin, the layers of the skin are as follows: the epidermis, dermis, and hypodermis. The epidermis is a waterproof barrier protecting the body from environmental pathogens. From top to bottom, the layers are easily remembered by the mnemonic Californians like girls in string bikinis, which stands for stratum corneum, stratum lucidum, stratum granulosum, stratum spinosum, and basale. The dermis is composed of tough connective tissues, fibroblasts, collagen, hair follicles, sweat glands, and mechanoreceptors. It is comprised of two layers. The upper papillary layer is made of loose areolar connective tissue. Underlying it is the much thicker reticular layer composed of dense, irregular connective tissue. Lastly, the hypodermis, which consists of adipose tissue. Moving on to the definition of terms, lymphocytes have a large dark staining nucleus with little to no eosinophilic cytoplasm. In normal situations, its nucleus is approximately the size of a red blood cell. Eosinophils have a bilobe nucleus resembling Ray-Ban glasses and contain strongly eosinophilic or bright pink granules. Mast cells have a round nuclei surrounded by ample cytoplasm, giving it a fried egg appearance and is seen in chronic inflammation. Spongiosis is mainly intercellular edema or abnormal accumulation of fluid in the epidermis, resulting in separation of keratinocytes, thus revealing the desmosomal attachments. Scale crust is made up of parakeratotic debris that generating inflammatory cells and tissue exudate on the surface of the epidermis. We will now proceed with the histopathologic correlation. Clinically, our patient has a textbook description of irregularly linear, thin, raised serpiginous burrow that is 2 to 3 millimeters wide. It's interesting to note that the visible tract does not correlate with the location of the larva. Based on Rapine and Lever's expected findings would be as follows. In the epidermis, a scale crust could be present with spongiosis and an intraepidermal vesicle that may have eosinophils. The larva can be visualized, although often difficult to find. In the dermis, there could be dermal edema with a perivascular infiltrate of lymphocytes, histiocytes, and many eosinophils. The tissue penetration and the movement of the hookworm larva within the epidermis are in part due to production and secretion of proteases by the parasite. However, these enzymatic activities are typically not adequate to allow penetration into the dermis, and hence, the nematode is located in the upper portion of the epidermis. Moving on to the histopathologic differentials, first would be strongyloidiasis or larva occurrence, caused by Strongyloides stercoralis, commonly called the whipworm. I rule it in because of the presence of the so-called filariform larva, accompanied by a surrounding inflammatory infiltrate with eosinophils. I rule it out because the location of the larva is found in the dermis, unlike our case, which is confined to the epidermis. There is also an additional finding of vascular damage, clinically producing purpura and petechiae, seen in this slide as extravasated RBCs, which is due to the larva migrating through the vessel wall. My next differential would be gnathostomiasis, also known as larva migrans profundus. It is the human infection caused by Gnathostoma spinigerum and or Gnathostoma hispidum, which infects vertebrates. It is acquired by eating undercooked or raw freshwater fish, eels, frogs, birds, and reptiles. I rule it in because of the presence of helminth parasite parts, accompanied by a surrounding inflammatory infiltrate with eosinophils. I rule it out because the location of the parasite is found in the dermis, unlike our case, which is confined to the epidermis. There is also an additional finding of denatured collagen fragments. My next differential would be onchocerciasis, also known as river blindness, which is a disease caused by Onchocerca volvulus. I rule it in because of the presence of helminth parasite accompanied by a surrounding inflammatory infiltrate. I rule it out because the location of the parasite in the form of microfilaria is found migrating freely in the dermis or within adult female worms, unlike our case, which is confined to the epidermis. The infiltrate is also reflective of chronic inflammation and mast cells could be present. My next differential would be diropilariasis, which is an infection by parasites of the genus Dirofilaria. It is transmitted through a mosquito bite. Its main hosts include dogs and wild canids. These can give rise to granulomas in the pulmonary artery. Some common symptoms include cough, fever, and pleural effusion. I rule it in because of the presence of helminth parasite accompanied by a surrounding inflammatory infiltrate of lymphocytes, histiocytes, and eosinophils. I rule it out because Dirofilaria can be identified by its thick, laminated eosinophilic cuticle, large lateral cords, and well-developed muscular layer. The location of the parasite is in the subcutaneous layer, unlike our case, which is confined to the epidermis. Additionally, the inflammation is primarily granulomatous. My next differential would be cysticercosis, which is caused by larval cysts of the tapeworm Taenia solium. These larval cysts infect the brain, muscle, or other tissue. I rule it in because of the presence of helminth parasite accompanied by a surrounding inflammatory infiltrate with eosinophils. I rule it out because the location of the parasite is found deeper in the subcutaneous layer, unlike our case, which is confined to the epidermis. The parasite can also be identified by its head region called the scolex. My last differential would be trichinosis, caused by Trichinella spiralis, also known as the trichinoworm or pork worm due to it being typically encountered in undercooked pork products, and should not be confused with the pork tapeworm discussed earlier. It mainly affects the striated muscles, causing intense muscular pain and various complications caused by larva migration throughout the body. I rule it in because of the presence of helminth parasite accompanied by a surrounding inflammatory infiltrate with eosinophils. I rule it out because the location of the parasite is found deeper in the muscle layer, unlike our case, which is confined to the epidermis. The parasite has a spiral or coiled appearance, hence its name Trichinella spiralis. So in summary, all differentials have the presence of helminth parasites with accompanying inflammatory infiltrate with eosinophils. In terms of location, cutaneous larva migrans is found in the epidermis. Strongyloidiasis, gnathostomiasis, and onchocerciasis are found in the dermis. Diropilariasis and cysticercosis are found in the subcutaneous layer, while trichinosis is found in the muscle layer. In strongyloidiasis, there is an additional finding of vascular damage. In gnathostomiasis, there is degenerated collagen fragments. In onchocerciasis, there is chronic inflammation with mast cells, and the parasite can be in the microfilaria form or adult female worm. In diropilariasis, the parasite can be identified by its thick, laminated eosinophilic cuticle, large lateral cords, and well-developed muscular layer with accompanying granulomatous inflammation. Cysticercosis can be identified by its head or scolex, while trichinosis appears spiral or coiled. Thank you for your time and attention.